and you get it down to 7, that is successful outcome. Can you imagine one of your crowns that half fits? Right? This is the whole thing. So what we're looking at is an ability to, number one, get the apneic disorders down to 0, which is where they should be for kids. And secondly, how do we maintain that? That's the big one. That's where oral myology really comes in. We want to look really at teamwork. And the team is ear, nose and throat, sleep physician, dentist / orthodontist, speech pathologist / ophthalmologist. You need that team approach. Okay? Phenotyping, I'm going to explain to you the sort of individual that you'll look for. We've worked it out cephalmetrically. So a patient whose maxilla is retrognathic, mandible is retrognathic, and has a long face. That's the phenotype that comes up all the time with this disorder. So it's what we call a class 4. Right? You all know class 3, right? You know class 2. If both maxilla and mandible are too far back, of course, all those areas of the pharynx, nasopharynx, oropharynx, hypopharynx, are all compromised. So we need to get those jaws forward. Does that make sense? The longer the face, the more the mandible rotates back, also impinging on the airway. So a simple cephalometric analysis would help you to get that correct, right? Just Philip, are you able to go on the feed and make sure the audio is good and they can hear?
Yep.
The last, yes?
Yeah, perfect.
Yeah. One thing, Andrea, I didn't realise, the first time we're using this room as a lecture thing, the noise outside is just diabolical. I never obviously spend any time in my waiting room, so to me it's beautiful, but you hear that noise all day, right? We need to get my mate Coco to soundproof that, because that's annoying, right? For me.
I need to sit it down.
CPAP, bit of controversy. If a kid has severe problems, you need to put them on CPAP, because it's dangerous, right? But long-term CPAP use is not good. Why? Long-term CPAP use will affect the forward growth of the jaw. You get what I'm trying to say? So kids are on CPAP for many years, and some of the patients I've been treating, 5, 6, 7 years on CPAP. Their top jaw doesn't grow forward. So they all end up almost like a cleft palate kid long-term, needing orthodontic surgery. So you're fixing one problem, creating another problem. You understand? But CPAP is important. And I'm going to show you how, once the diagnosis is made, how we take the patient off CPAP during certain stages. For instance, when we expand the maxilla, there's more need for CPAP. Why? Tongue is in a more dangerous position for blocking the airway, etc., etc. Right? I'm very lucky to work with very good sleep physicians, and I thoroughly recommend Dr. Jim Papadopoulos. Jim is in a number of locations, and he really gets it. He understands the link associated with sleep disordered breathing in these children, restless leg syndrome, believe it or not, constipation, right? GERD. So this kid, when I look at medical history, they have RUX, they have restless leg syndrome, they're constipated, they have GERD. It's a classic thing. And yet we don't look for those, but you see it when you do a further sort of investigation and ask the right questions. So let's talk about this. Now, why am I interested in this? Look at this girl. This girl is class 4. Her maxilla's back, her mandible's back, she's got a long face. Can everyone see that? She has had orthodontic surgery. I'm very lucky to work with a couple of good max back surgeons, in particular Dr. Greg Lavoff, who'll be one of the speakers here. Greg is dual qualified, medicine, dentistry, max back, ear, nose and throat, right? He knows how to fix airway, but unfortunately, at this age, I can't use the protocol I've been talking about. The horse is already bolted. But what I want to tell you, that this girl has been like that since she was 7. Do you understand? Right? And if you treat her now, yes, you get a beautiful face, but look what the kid has to go through. But look at the improvement in the airway. Look at her narrow palate. Right? Let's talk about narrow palates. Did you know, research from Maurice, one of the papers I review on the PhD group, Maurice looked at children from birth till 21. He took impressions of their teeth and he looked at their study models. You understand? The kids who didn't need any orthodontics, who had a nice broad arch form, their intermolar distance from first molar to first molar was roughly 37 millimeters. Does that make sense? Right? As they got older, the intermolar distance didn't change. Do you follow? So most dentists say, kid's only 7, wait till 12, 13 and see how much their jaw grows. Guess what? After 7, the width is not going to change. Do you understand?
No.
And between 7 and 9 is when you get maximum growth of the upper jaw. So that's the time you've got to treat these kids. You get it? So if you come from the same orthodontic education I came from, treat a kid orthodontically when they have all their broken teeth. Yes, that's what I was taught. Both undergrad and postgrad. Right? Back in the day where orthodontists were real men and premolars were very nervous. You know what I'm saying? Do you think pulling out 4 teeth when there's no room at age 13 is going to improve the airway or worsen the airway? Do you think the tongue's going to have more room or less room? Common sense, all common sense. Right? Okay, so how do we measure? We use what's called RDI. Why is RDI more important than AHI? By the way, Andrea, is the feed good? Yes, no?
Yeah.
Yep.
Volume?
Yeah.
You
Yeah,
sure?
so, yeah, I'm just checking the lights now and the cancer.
These guys have been mucking around with this all day, and I said, look, just get it right. Because last time I did this, 10,000 people complained that they couldn't see anything or hear anything. So they switched off in 5 minutes. Today,
I'll be right here.
why is RDI more important than AHI? AHI is the apneic events and the hypopneic events per hour, right? So it's when a patient stops breathing or has partial obstruction, right? But you could not have any AHI and still have sleep disordered breathing because you have nasal obstruction. If you have nasal obstruction, there's a lot more effort to breathe. And this is what we call a RERA, right? So if you add the RERAs, the increased respiratory efforts, with the apneas, that's a better indication. Make sense? So when you get in your sleep studies, you need to find a sleep physician that measures RDI, not just AHI. You need to find a sleep physician that measures bruxism, because many of them don't. Many of them just put electrodes on the leg because they're looking for restless leg syndrome. We're looking for temporalis and masseteric overactivity, and we'll talk a little bit about that as we go, right? So, 15 years of my life have gone into this. I've saved a lot of kids, I think, from really bad outcomes. Kids have been on CPAP, I've taken them off CPAP. Kids have been not doing well at school. Kids who've been deemed hyperactive. So to me, it's very, very rewarding, you know. As I said, I only ever did 1 root canal in my life, and I created a few extra canals. You understand? But I don't think any of your patients ever thank you for root canal therapy. Am I right or wrong? Yeah? I get letters every day from parents. Do you remember like young Johnny? He was really flunking school. The teacher wanted to repeat him. You made the diagnosis. You fixed him. Now Johnny's at the top of his class. He's in selective school. Make sense? It's really important. It's the most important thing you'll do as a dentist. Make sure you understand. You look at the oral cavity. You're the gatekeeper of the airway. Do you know how much bullshit I hear about how to stop a kid gagging during impression? I've heard salt on the tip of the tongue. I've heard look at your eyes in the mirror. I've heard lift one leg and then you probably know all the little old wives' tales, right? Do you think that the kid is gagging because his airway, his only way of breathing, is now being compromised? Think about that. What percentage of these patients were gaggers? I looked at everything, right? High percentage were gaggers because they had upper airway problems. So common sense stuff. Things you see in dentistry, you don't associate with this, but they are. Abfracture lesions. That's the kid bruxing. Why are they bruxing? They're opening up their airway. You understand? Large tonsils. Uvula, that's red edematous. Long soft palate. All these things you see and you pick it up early in the mouth. And you'll see how much of it relates to what I'm talking about. So, big number, just under 4,000 kids. The biggest problem I had to justify the academics is what? What do you think? A control group. So in other words, I had to present to the ethics committee that there's patients who have sleep disordered breathing, but I'm not going to treat them. Right? How do you think I got that control group? Well, luckily, some parents aren't too bright. I'll just say it, maybe because they have sleep apnea all their life. And they say, my kid's fine. We have a contest at home who snores more, dad or the child. It's all good. Right? The whole family looks like the Simpsons, yeah? So I say, listen, no problem. No need to see ear, nose and throat. No need for a sleep study. Why don't you just come back every year and we'll keep an eye on it? Fantastic, my control group. Not good for the kids. Right? But interestingly, off that control group, 2 got better without intervention. So there you go. But I have to tell you why. They lost a lot of weight. They were little chubby kids. They started doing sport. And the weight loss made a difference. Do you understand? The others got worse. Right? Until I couldn't bleed out the control group anymore. Does that make sense? Right? But just so you understand, like, it's very hard to do a full scientific study. Who reads Cochrane database? Who realises everything in Cochrane database ends with the same conclusion? Not enough evidence to support shit. More research required. Does that help you in clinical practice? Honestly, I still have to work for a living. Yeah? I'd love to say I'm a quasi-academic, yes? But ultimately, I want to know, how is the research going to help me tomorrow in clinical practice? How's it going to help my kids? Make sense? Right? So even if one kid got better, and I did a case report, which is down here in literature, do you think that's worth reading? I think it is, because maybe you learn something from that one individual. I thank very much Maria Villa. Maria Villa is a medical doctor. And then in Italy, back when she trained, to become a dentist, you had to do medicine first, which is, I think, the way it should be, right? Because to understand what I'm talking about, you need a medical degree before you do dentistry. And it just makes logical sense. After doing those degrees, she went on and did further research in sleep medicine, and she runs a magnificent clinic in La Spezia University in Rome, right? And I share a lot of data with her, because the only group I didn't have in my study were patients who were treated purely with myofunctional therapy. She has that data. Does that kind of make sense? To me, I couldn't find patients who had OSA that I could say to them, listen, all you're going to do is oral myology and we'll see if you get better. Yeah, right? Now, believe it or not, one of the best ways to treat snoring and sleep apnea in an adult is to learn to play the didgeridoo. Who understands that? Because all these muscles, and it's in the literature. British Medical Journal, 1988. Go read it. Okay? However, I think it's a great finishing. So I thank Maria for opening up my eyes to a big problem. Right? And the more you read, the more you think, oh my God, am I ever going to finish this research? Because it opens up another door and another door, etc., etc. Right? So what we're looking at is orthodontic treatment. Now, I use the word orthodontic treatment because I'm an orthodontist, but really the correct term is dentofacial orthopedics. Do you understand the difference? Orthodontics is moving teeth around. Moving teeth around doesn't make much difference in these kids. Understand? Moving the jaw around makes the difference. Widening the palate slowly so that the high vault remodels this way, opening up the airway, right? Bringing the lower jaw forward, or in some cases, bringing the upper jaw forward, or in some cases, bringing both jaws forward. Does that make sense? This is all orthopedic. So what the kids need. The 2 common disorders I found were maxillary deficiency with a normal mandible that looked like class 3, class 2, which is normal maxilla, mandible retrognathic, and of course, both jaws back. So anything that's retrognathic is not going to be good. Who would agree? A good airway is a good looking face. 100%. Right? So as we go through all this, we realise there's a role for all of these, but the thing is, everyone's working in isolation. And it's almost like putting the bits of the jigsaw puzzle together. So let's go through the definitions, okay? The definition of obstructive sleep disordered breathing, right? It's a syndrome of upper airway dysfunction during sleep, which is characterised by snoring and or increased respiratory effort, which we've talked about, right? So you have collapse of the pharyngeal wall, yeah? So what are some of the clinical entities? Primary snoring, that's why you've got to ask that question. Then you have upper airway resistance, very common in kids with nasal valve collapse, deviated nasal septums, enlarged inferior turbinates. Michael, you're a medical doctor. How many kids have you seen in your life 7 years old with upper airway problems? Probably all of them, right? I mean, in Australia, we're a nation of migrants and sports people. So either break your nose or you have allergies because you shouldn't be living in this environment. How does that sound? Right? All these kids can't breathe through now. They develop this open mouth posture. When they develop the open mouth posture, the buccinator wins the war because the tongue is not doing its job. That's what collapses the airway. The narrow maxilla has a roll-on effect with the mandible. Do you understand? Real common sense stuff. And we'll talk about recurrent middle ear. Otitis media. How many of these kids in my study had otitis media? Had 1 set, 2 sets, 3 sets of grommets. Why? When you swallow with a nice palate, with your tongue hitting the palate, 2 muscles work. Tensor levator palatini. You understand? So if you swallow now, see if you can hear something in your ear. Right? That's clearing off the eustachian tube. But if you've got a narrow palate, a tongue thrust, and your soft palate's not functioning because adenoids live on top of it, guess what? This doesn't clear. Hence you get recurrent need for antibiotics and then grommets, but still not fixing the problem. Does everyone understand that? Right? Oh, sorry, go back. This is the dangerous one, but as I said, all the research is mainly just on OSA, so it gives you a very narrow sample group. But someone could not have apnea and still have nasal obstruction, which is causing the problem. Does it all make sense to people? Right? Now, here's some interesting facts about children. It's Australian stats. A child who snores is 4 times more likely to be in the bottom 25% of the class. So do you think it's important to ask if the child snores? A child with sleep apnea, right, that's the dangerous part of the class, 9 times more likely to be in the bottom 10% of the class. And here's the biggie. Nearly half the patients who were diagnosed with ADHD and put on stimulant medications such as Ritalin actually didn't have ADHD. What they had was a sleep disordered breathing. Does that make sense? Okay? So these are the things you need to look out for. So what we did our standard orthodontic records. It's not as I was putting these kids through anything other than what they needed. Now please understand, the sample came to me from an orthodontic group. Most of the referrals were from dentists. Do you get what I'm trying to say? It's not as though I had respiratory physicians referring me patients saying, hey, this kid has OSA, can you treat them? I couldn't put that in the sample. Do you understand? Because that will cause bias. Make sense? We even had to do weird things to get the scientific thing. We had to put expanders in where the screw wasn't working. Because that's the control. Do you understand what I'm trying to say? Okay? But at the end of the day, we looked at everything a normal orthodontist looks at, which is digital models, facial photographs, x-rays. The difference was we measured the sleep. Does that make sense? And I thank Jim Papadopoulos for really helping me to help these patients pay for their sleep studies by doing a lot of Medicare-based studies, which is important because for my research, we had to have a baseline. We then had to see what their sleep was like after ear, nose and throat, after orthopedics, after MFT. Does that kind of make sense? So some of these people had 4 sleep studies. And that's important because the data had to show that they were here, they got here. Now, if they were here and they stayed here, why would you want to do anything else? Does that make sense? You got what I'm right? So everyone should have the Bears screening form. Who uses this? Someone, right? Julie, what sort of feedback do you get from parents?
Light bulb.
Yeah, light bulb goes off. They go, oh my God, that is my kid. Now you can download this, you can email me, I'll send you it. And basically, it's an instrument that divides 5 major sleep domains in kids. And each of the domains has a set of age-appropriate trigger questions. The parent fills this out, you then look at the score, and the higher the score, the higher the risk. Does that make sense? So it doesn't cost you anything. So why don't you consider in all your kids, right, to just ask the parents to fill this out. And if this comes back red flag, maybe then consider doing some form of at-home sleep study. Now remember, by law, you can't do a PSG for a child unsupervised, right? But what you can do is measure oxygen saturation. And one of the papers shows nearly 80% accuracy with just measuring oxygen desat for a child versus a sleep study. And that's non-invasive, and the machine costs about $150. So to get the parent to the table, Bears questionnaire, snore app, pulse oximeter looking at oxygen desats. All make sense? Right? So when we found these kids, we divided them into these groups. Those who had ear, nose and throat surgery only, mainly adenoid tonsils, sometimes turbinate reduction, they're the most common. Those who had ear, nose and throat and myofunctional therapy, but the myofunctional therapy was an appliance at night called a myo brace with actual exercises during the day. Any oral myologists here, speech pathologists at all? Yeah? You familiar with that? The spot, yeah? Tip of the tongue on the palatine rugae, really important for opening up the airway. Right? Those who had ear, nose and throat and just treatment with me. Those who had ear, nose and throat treatment with me and myofunctional therapy. Does that make sense? And the control. Now, what do you think had the best results? I mean, to me it's bleeding obvious. What do you think? Who says the control? Right? So the thing is, if there's no evidence though, you can't just say to your parent, hey, your kid's got a problem, here's your pathway. And we mixed up all sorts of things. We did, whatever we did this first before that, you could milk about 100 papers out of this, looking at the same data. Okay? So, we had sleep studies at baseline, then we had sleep studies following all the things we did, and at the end of the day, the kids who got the complete resolution, really, changed children, were those who had the appropriate treatment at the right time and multidisciplinary treatment. All make sense? Okay? So, a couple of things. When you take x-rays, you've got to have a standardized position. I want you to Google Metz protocol. James Metz came up with a great way to get Frankfurt horizontal parallel. You basically look at your own eyes in the mirror. And if you do that, it's a reproducible x-ray. The second thing is, when you take the x-ray, you get the patient to breathe in and then breathe out slowly, and just when they're about to expire, take the x-ray. That reproduces the anatomy of the airway. Otherwise, I've done it on myself. I've taken 3 CBCTs 5 minutes apart, and my airway volume was different in every x-ray. Does that make sense? But if you reproduce the protocol, you can compare apples with apples. So if you're doing CBCT or referring for CBCT, it's important that you follow that protocol. And by the way, I don't know whether they're still here, I should have mentioned them. All my radiology and all my practice I do through a big group, and they're known as SMI. They have the most beautiful x-rays. If you're here who here's from the eastern suburbs, just out of interest? Okay, so they've opened a new location here called RMI, Randwick Medical Imaging. Bulk bill all your x-rays, right? Including CBCT, including full CT, OPG, lateral ceph. Very, very good, right? And, the problem in medicine is if you refer for a dental x-ray, the report you get back is normally teeth are present. Who's had those reports? Right? I want a proper airway report. You get it? So you need to find someone who has a good x-ray and interprets it properly. So that's part of the protocol. I got the parents to take a little video of their kids sleeping or a photo. So I looked at their posture. We had the thing. So all of this gave me my data. And then from that, we had airway intervention, including lip and tongue tie. Who can tell me why a tongue tie is important to be released when it comes to OSA? Anyone? There's 6 papers that actually go through this. What's the theory? Why do you think someone who's tongue-tied has a higher chance of these problems? Yeah, because when your tongue's here, the back of it can't elevate to where it should. It goes on the back of the airway. It blocks the oropharynx. How many dentists have really been taught how to look for a tongue tie? Who can give me the exact protocol? Well, come on the Facebook group and I'll show you. Audrey Yoon, another clever doctor, dentist, became a pediatric dentist, then became an orthodontist, then did sleep medicine. I think she gets it. Her paper, classical paper in sleep, shows a correlation between tongue tie and OSA and shows you which kids are at risk. How do you do it? Very simple. You get the kid to open and you measure their opening. You then get the kid to put the tip of the tongue on the incisor foramen and you get them to open again until they release. You understand? When the tongue releases less than 50% of normal opening, that needs a frenectomy. You get what I'm trying to say? And if you really understand, most of you only look at the anterior frenum. Half the kids who are tongue-tied have a posterior band attachment. And if you don't release that, you're still not doing the good thing, right? So that's a whole nother lecture. Who would agree? All right? But it's really important. And when you work with good ear, nose and throats, they get it. Lvov can do T's and A's, turbinates, and tongue release all in one operation. How good is that? Yeah? But the thing is, even with his magic, these kids still have residual RDI. You get it? They're better, but they're still mouth breathers. We teach our kids how to walk. We teach our kids how to talk. We need to teach them how to breathe through their nose. Trust me. So that's where MFT comes in. Might sound silly, but you know how many times I go to sleep and I dream about this, telling my kids every day, mouth together, lips together, breathe through your nose, tongue on the palate. Lips together, breathe through your nose, tongue on the palate. That's very effective retention from my orthodontics, right? And helps stimulate good growth. Why? Because if you sleep well, growth hormones are released correctly, which facilitates normal growth. Understand the link? Right? So I'm very lucky to be able to teach these students. This is where I do my PhD. And every year they graduate 8 wonderful orthodontists. Why did I say wonderful orthodontists? Because from day one they're taught all this. So they graduate with an understanding of everything I'm talking about. Whereas an average orthodontist graduates with what? The knowledge on how to straighten teeth. Who would agree with that? That was me back in the day. When I saw class 2, I didn't think airway. I thought, oh my God, those teeth stick out. Right? Let's get those incisors back before Easter. Does that make sense? You know, you don't want a kid with an overjet during Easter. Right? You're probably really busy. This is what the kid needs if you do the sleep study. Yes or no? Right? That's the faculty, great research department. Now, what's important about these people? Right? He's previous head of department, he's current head of department, he's my visiting examiner. They all have medical degrees before dentistry, before ortho. Do you get the picture how good this faculty is? Does anyone know this guy? George Lee probably does. He's your age, George. But he's dead. That's Rob Ricketts. Yeah. Ricketts was one of the first orthodontists in the world to start talking about treating kids. Can you believe that? and treated them in mixed dentition and airway. To this day, his airway analysis is still a common analysis cephalometrically. He taught this guy, right? And this guy became head of department. Do you understand how good this place is, right? Not to mention, everyone raves about the, what is it, Maclaurin Hall in Sydney, is that the one? You know how old this faculty is? Yeah? Unbelievable place to go and visit. Right? So we've published a lot of papers out of this, and obviously I'm going to be publishing a lot more. Why? I want to get the information out there. This is a good starting paper. This was published in Australian Orthodontic Journal, believe it or not. Right? One of my colleagues, Linda Aronson, you've probably heard of him, he did the first adenoid study. He looked at kids who had large adenoids, who had no treatment, kids who had large adenoids, who had the adenoids removed and then were taught how to breathe through the nose, and the control group who were normal nasal breathers. Make sense? And what did he find? He found that kids with mouth breathing, large adenoids, end up with longer faces, narrower maxillas, more class 2. Makes sense, doesn't it? Right? But he was the first guy to do that. What I looked at in this paper was how the mode of breathing affected their face height. So as I said to you, the longer the face, the more retrognathic maxilla and mandible, the higher risk of the syndrome. Everyone getting that picture? Right? You can see, you can pick these kids after a while. So we come up with this sort of pathway, and I show this to parents all day long. I say, listen, your tongue's in the wrong position for a number of reasons. Could be tongue-tied, could be because you can't breathe through the nose, could be because you suck your thumb, could be because you're on the pacifier. Whatever it is, it's causing your palate to narrow. Your palate narrowing is going to affect your breathing and, of course, cause an orthodontic problem. Right now, we want to fix the breathing. If we fix the breathing and we develop the palate and you get the tongue in the right spot, there's a high chance you may not need orthodontics in future. That's the motivator. You understand? Right? And when I read the research, remember, I've read over 5,000 papers for this study, and I've actually read them cover to cover. What I normally do is I read it in the morning, I read it at lunchtime, I read it before I go to bed, the same paper. The third time it sinks in. Who would agree or disagree with that? And then before I forget it, I shoot a video the next morning. Right? This is 1909, okay? Dental Cosmos, which was a precursor of the American Dental Association JADA. Right? Look what they're saying in this paper. Habitual mouth breathing and consequent malocclusion. So people have been talking about this for over 100 years. And look what they're saying. We should work with the medical profession, I agree, right? And the closest way of working with them is in the treatment of rhinology, or ear, nose and throat, and orthodontia. Of course there's a link. We work below the palate, they work above the palate. We both need each other. And signs of mouth breathing affect sleep. The chin recedes, class 2. The dental arches are constricted, teeth become crowded, right? And here's the best thing. Teachers will accuse children of being inattentive at school. 1909. Why didn't they do bloody something about it then? Shouldn't have someone done a PhD back then? Yes or no? Now remember, when I went to dental school, I had to learn about the setting properties of gypsum. Who remembers those great lectures? Or what's that bullshit you make dentures with? Shellac? I spent years trying to get the Bunsen not to burn their shellac. What the hell? One lecture on Airway, please. When I become Prime Minister of Australia, I'm not kidding. A, I'm going to abolish APRA. B, I'm going to make it compulsory for everyone in every health science to have a lecture on airway. How does that sound? And diagnosis of pediatric with simple goals. Right? Okay. So, they then talk about expansion early. Right? Look at the year this is published. brain development retarded. Let me tell you something. If you're an adult and you have this syndrome and it's not diagnosed, you will die 10 to 15 years earlier. How does that sound? If you're a kid, you'll lose 5 IQ points per year. Who understands IQ? What's the average IQ? Any idea? I'll give you a little hint. Einstein was 190, right? So was Professor, who's the guy who's in the wheelchair? Stephen Hawkins? Hawkins, yeah. They're about 190. So what do you think average is in? That's mine. Yeah, 90 is right on the middle of the bell curve. Now, if these kids have this problem, undiagnosed 3-4 years, guess what? They're losing 20 IQ points, which they'll never recover. Do you get what I'm trying to say? So forget about their teeth, forget about their face. What about their, ability to perform well? Yes? No? No? Anyway, so I'm going to just flick through the papers because there's literally hundreds of them. And I know tonight it's going to go in one year, out the other. But I've got papers that show you how to assess nasal airway. I've got papers that allow you to look at CBCT so that you can look at these pharyngeal collapses. Look at this kid, right? He's referred to me at 14 for an orthodontic consult. His dentist has been seeing him every year since he was in kindergarten. What do I say to that dentist? Do you think I get a bit angry? I don't have to say to Mum, Mrs. Jones, unfortunately your son has a narrow jaw, he's obviously got sleep apnea, he's got a long face, I can't do anything for him now, let's wait till he's 19, finishes HSC, then we're going to do a Bimax osteotomy. It's going to cost you about 50 grand. Yeah? But it's what your child needs. Or I can be the lazy orthodontist and take out 4 teeth. Yes or no? If I take out 4 teeth, will it improve his airway or his facial appearance? No, of course it won't. So that's the age I want to see the kids. Yes or no? From 7 onwards, this develops and the intermolar width is set, so I know what to do. Between 7 and 9, I get maximum growth of the jaw. Now, in my study, I had older kids, and they got improvement, but not nearly as good as this. So that's when you want to treat that kid. Do you understand? And as I said, we just had Easter. If you're Greek, who's Greek here? Decanius. Right? Your Easter this weekend. How do you think that kid feels at school? Do you think they get teased? Do you think that kid has a high incidence of incisal trauma?
Yes.
Do you think that kid sleeps well at night? So what are you waiting for? Look at the kid's palate. Just measure that distance. Increased chance of caries because they mouth breathe, yes or no? Do you get what I'm trying to say? My biggest frustration with my profession is they're waiting for this to do orthodontics. You understand? Right? So, when you do a PhD, you leave a legacy. You've got to do something that no one else has done before. Does that make sense? Right? So I'm hoping that when I die, all of you will come to the funeral. Some of you, right, will be genuinely sad. It'll be the biggest funeral in Sydney, by the way, dental community. I've already booked the cathedral. But most of the people who will be there will be my colleagues, my fellow orthodontists, to make sure I'm going 6 foot under. You understand? Because they don't like to know this. Because then they've got to change the whole way they do business. Yes or no? But I was the same. I didn't know all this when I graduated. I would wait till the kid was that age. I'd take out 4 teeth and I'd pull the teeth back towards the adenoids. Seriously. I was trained in the big technique. Anyone heard of that? Round wire, lots of elastics. Everyone ends up looking like Julia Gillard. You know my political aspirations now, Frank? It ain't green. Okay? All right? So, quick anatomy lesson. When you take your x-rays, if you take them in 3D, it's better than 2D. Happy? The biggest collapse in some of these kids is the nasal valve. And you can actually examine that. Go to my YouTube channel and I have a little video on examining all the parts of the pharynx. Nasal valve collapse is important. And you can do something for a kid to fix that non-surgically. Then we have if you look in the nasal valve, you want dark space. The more dark space you have, the better the airway, right? So, on one side of the dark space, which we call the medial side, if you see a lot of that encroaching, that's the septal deviation. On the other side, if you see the encroaching, that's the inferior turbinates. You get it? Right? You then go here, and air goes through the nose, it's filtered through the tubes, then here it goes to the back of the nasopharynx. And this is where the adenoids and tonsils can be enlarged. You follow? So the correct term for adenoids is nasopharyngeal tonsils. Then you go down, and the next area of collapse, which is not written here, is behind the palate, is known as the velopharynx. And that's when your maxilla is too far back, or you have a long soft palate, or both. Then this is where you should kill it, oropharynx. So you look at the Mallampati index, and I'll go through all this with you in YouTube videos. Right? I want dentists to start looking at the fourth molar. How does that sound? What's the fourth molar? The tonsils. You guys have the best torches or lights, right? You have the kid in a captive position. You're going to be able to look down there and just get the kid to go R for Mallampati, press the tongue down for tonsils. You're going to do the... I've got a little video on all of this. If you add the 5 videos together, total investment 15 minutes, you'll learn a lot. How does that sound? And then maybe you'll start not focusing when the kid sits down. Oh my God, what's that probe? Sickle, right? You know, gold in them hills? Yeah. You're not going to go, oh, that's catching. Let's seal it. While the kid's... But he's going to die with beautiful enamel, caries free. How does that sound? He'll be the dumbest kid in the class, but he'll have beautiful teeth. Seriously, I mean, I'm being a bit facetious here, but, you know, general dentistry is way beyond me. Okay? I really want you to understand, I can't be in all the practices saying, oh my God, of course that kid's got problems. You need to educate yourself, all right? And then we go to where the nose and throat doctor gets involved in this part, right? Okay, now, Andrea, what time did we advertise this to finish? I mean, I can talk all night, right? But obviously, 7 till 8? Or what time is it now?
8:30.
8:30? All right, okay. Look, there's so much stuff here. There's 1,000 slides, just so you know, in this presentation. We've just covered 25. Okay? I'm happy to send you the slides and the studies, but you're far better off joining me on the PhD Facebook group because you don't have to read the paper. I'm there in a video going, by the way, this paper, blah, 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 blah. Okay? I just flick through... Yeah, so let me just end the lecture by defining class 4, okay? So, a good-looking face will have the maxilla and the mandible in the correct position to the cranial base. Everyone understand that? 7 is when the cranial base stops growing. Before 7, you don't really know where the maxilla or mandible should be. Hence why I want that consultation at age 7, right? And it's not just me. I mean, you know, American Orthodontic Association, most powerful orthodontic body in the world. What do they say? First age consult, age 7. Go on their website, they talk about airway. They talk about all of this stuff, right? So, if you widen the palate and bring it forward, you can help this kid. But the kids I'm seeing have the maxilla back, or the mandible back, or both back. And the class 4 is both of the upper and lower jaws being retronative. Now, how do we know this is working? Because surgeons have been getting nearly 100% improvement in their patients by moving the jaw surgically forward. Do you understand? But when you're a kid, you can do it non-surgically. Yeah, everyone get the picture? But the older you get, even 14 is too late in the day. You can still do some expansion, but you can't really bring the jaw forward. And this is a big operation. Don't let anyone kid you, right? But it works. Look at the airway width, before and after. But look at that. You understand? Right? High angle, maxillary deficient mandibular, class 4. And here's all the papers. You know, so my question is, what about the children? This is what some people are doing. And I'm not saying it doesn't work, but it's like getting the kid on a therapy that's never going to actually get them off that treatment. Does that make sense? Yeah? So please understand, this is a good paper that talks about what happens with these kids. So to get them off that, can everyone see that kid's face? To get them off that and get their jaws forward, does that kid look better? Absolutely. Is that kid sleeping better? Absolutely. Has that kid got less dental crowding? Absolutely. Why wouldn't you do that for your kid? Right? So, this is Maria Villa's research. And proud to say, Maria Villa has had a big influence on the European Sleep Association, right? Respiratory Society. Now look at her protocol. Multi-edgewise therapy, orthodontics, nasal CPAP when needed, adenoids, beautifully listed. And look here, oropharyngeal exercises. If there's persistence after steps 1 to 3, very good protocol. Okay? So it's already been documented and the Europeans are using it. What are we doing in Australia and New Zealand? Do you understand? So go out there, find a good ear, nose and throat doctor to work with, find a good respiratory physician, find a good orthodontist, or better still, learn how to do the orthopedics yourself. It's not that hard. It's not that hard, right? And the concept then is to get these kids while they're still growing. Can everyone see a beautiful face? Right? Age-appropriate treatment is what we want to do, and the term is obstructive sleep disordered breathing. Everyone understand that? All right, now we're going to have a quick quiz. Ready? Are we giving any prizes away? Where's Andrea? Normally we give away something. By the way, did you like my wine? So I only have 2 passions in life. Pediatric obstructive sleep disordered breathing and making good quality wine. Yeah? So the wines you're tasting today come from my estate. Yeah? One is called SBS, that's the white. It's not sweaty ball syndrome. It's Sauvignon Blanc with a touch of Semillon. Yeah? So if you like your Pinot Gris, but you think Pinot Gris is too fruity, and you think Sauvignon Blancs are too dry, that's your wine. Yeah? And the big daddy is a Pinot Noir combined with Cabernet Sauvignon, just the right mix. Aged in French oak for 3 years. Now you're going to start wasting money. Anyone have any idea how much a barrel of French oak costs? Well, not assembled, €3,000. Put it together, char it, and you can only use it for a couple of seasons. Does that make sense? No? So to me, that also is very passionate. So what I'm hoping is we can stay back, answer the questions, drink some good wine. All good? So any questions? Audio's good? Right, who's picking up the online questions, or are you just gonna, you can answer them, Felipe? Right? Actually, Merrick here, see Merrick with the camera? Merrick is my driver. He drives me everywhere, right? And it might sound pretentious, but I have 6 practices, and Sydney traffic's a bitch. Who would agree? So I sit in the back of the car, Merrick does all the hard work, and you know, I read all these papers and do all my things. It's beautiful. And Merrick's been to every lecture I've given in the last 6 years. Right? So one day he said, you know, Derek, I think I can do that lecture. I said, go ahead, it's true story. Be my guest. Right? So anyway, I showed up at this. I think it was the that society, some dental society in the North Shore, right? Merrick gets up
And he goes through, and oh my God, I'm at the back door, perfect. Knows his research, right? And then I was waiting for it. At the end of the lecture, someone asked a question in America. He goes, oh my God, that's such a stupid question. Even my driver down the back can answer that question. True story, right? So today, you got the non-driver answer. Any questions on what I presented? Does it make you think differently? Yes, no? It's really important. It's really important. And there's so much literature, but there's so little being done. That's the problem. Now, I'm not asking you to go and treat the world. Why don't you just help? Why don't you set a goal that when you come back to work after your holidays, you're going to start screening 100% of patients? Here's question 1. What are the 3 most common non-invasive tools for screening for this disorder? Number 1, Bear's questionnaire. 2, Snore app, or there's many on the market. There's even those Fitbit things. Yeah. 3, yeah, pulse oximeter. Now the brave new world, where Colin Sullivan's research is going, he's developed a mat. So you borrow this mat, the kid sleeps on the mat, there's no electrodes, it picks up everything like a full sleep study. How amazing is that guy? He developed CPAP, by the way. Yeah? But right now, they're the 3 common things. From that, the medical diagnosis has to be with a full PSG. Everyone happy? Right? But if you don't want a full PSG, and it's obvious the kid has got large adenoids and tonsils when you do your CBCT, send them to the ear, nose and throat doctor first. But if the ear, nose and throat doctor won't pick up restless leg syndrome, where the treatment is related to nutrition, high iron supplements, you understand? They won't pick up GERD and constipation. You understand what I'm trying to say? So you can't just say all your problems are related to this. Yeah? You can't just say all your problems are because you have a narrow maxilla. You've got to look at the kid holistically. That's why it's important to have a good sleep disorder breathing team. Okay? Question number 2. Difference between RDI and AHI. Anyone? This is where I see if the audience was actually awake or asleep. Yes, RDI is more accurate because it includes respiratory efforts, not just apneas. So you get a whole picture of the kids who have this problem rather than the actual obstruction. Good? Questions? Come on, you must have some questions about, yes?
We have a lot of patients with 12 to 18-month-olds that complain about bruxism.
Yes. Yep.
Is that too early to...
No, sleep study. Pediatric bruxism, 4 main causes. Number 1 is large adenoids and tonsils, right? Number 2 is associated with restless leg syndrome. Number 3 is GERD, silent reflux, right? Number 4, believe it or not, higher than stress is intestinal parasites. You get it? So there's your answer. And I can give you all those papers, right? But no, it's not normal for a kid to brux and brux and brux. There's papers to show it's a transitional thing from primary to mixed to permanent, but if it's constant and you see the wear on these kids, it's not normal, right? And giving them a splint is not actually helping their craniofacial development or actually fixing the problem. So the answer is get a sleep study. You're right? And medical doctors don't call it bruxism. You understand? They call it a sleep disordered motor problem, such as sleepwalking is in that category. Restless leg syndrome is in that category. Do you get it? So it's actually a medical condition. We see it dentally because we see the wear on the kids' teeth. And you know, I've had many parents who said, Dr. Manny, my kid's only 4. We went camping the other day. It's the first time we've slept next to this kid, and they grind their teeth all night. What's going on with that? And I say, well, blah, 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 blah. Does your child have... So you can't just refer just for bruxism. Bruxism with bears, high. Bruxism with snoring. Bruxism with my kid's tired, or my kid's hyperactive and I want to kill him. Bang, sleep study. Who has those kids who... I had one today, it came in for a consult, wouldn't sit in the chair. It was literally like, you know, jumping up and down, and then... I could have never seen a kid do this. Slid down my dental chair backwards. Is that a normal kid? And the mum's there like highly dosed on Valium. She's used to this kid. You know? Yeah. What do you think I'm going to do for that kid? Clearly I know he's got some dramas going on. It's not the kid's fault. He has definite problems. So he's off to get a sleep study on Monday, and the mum can't get him there quick enough. Yes or no? How many of you have kids like that? And what do? You refer them to the paediatric dentist, who doesn't have any training in sleep bruxism. They go for GA, they wake up with stainless steel in their mouth. Yes or no? Do you think paediatric dentists like kids any more than you do? No, they just know how to put them to sleep.
Is sleepwalking a sign or a symptom?
Not with this, no. But it is. So when you sleep, there's 4 stages, right? Best sleep is non-rapid eye movement, right? Stage 3. That's when you get your refreshing sleep. Dream sleep is REM, okay? Now, when you have dream sleep, your muscles are paralysed. Why? So you can't act out your dream. Understand? But kids who sleepwalk are having, that's a neurological condition. Believe it or not, Frank, if you kill your wife, right, and your defence is, I didn't really want to kill her, I thought about it and I dreamt about it, and one day I woke up, right, it actually is a defence if you can show you have another condition, and you want to know the name of that condition. So again? Parkinson's. Good one. Good one.
Parkinson's disease causes the acting out a dream in REM sleep.
Exactly. So rather than be paralysed, you're actually acting out your dream. And bruxism is a form of that. You understand? Patients, so people who are stressed, they think out the day they had or the day they're going to have. Yes or no? That's during dream sleep. So they brux during REM. Sleep bruxism doesn't occur that much in REM. You understand? Sleep bruxism, you have a microarousal, and that causes that. If you don't understand, adults who brux, it's because mesenteric activity, hypoglossal ganglion, is stimulating genioglossus to bring the tongue forward. The body's very clever. So many people who brux actually have sleep bruxism. Best paper, Gilles Levine, University of Montreal. That's one paper you should read. More with adults, not with kids. Okay? Yep.
So I'm one of those people who have a low IQ because of my sleep sort of breathing. But I didn't quite get...
And unfortunately it's too late for you.
Unfortunately it's too late. But I didn't quite get your 4 reasons for pediatric bruxism. What were the 4 again?
Okay, in order of priority, and stress is not one of them. 4-year-olds are not stressed.
Yeah.
Even if they're in Catholic boarding school. Had to throw that in, Frank. Frank and I are the last remaining bloody Opus Dei, aren't we, mate? Yeah? Go into that room, you see every pope since I've been alive has given me a blessing. Yeah, right. So, number 1 is large adenoids and tonsils. Right, very common.
And then I got
Number 2, well, these people walking past, oh my God, that's my kid, yeah. Should beam this to the... number 2 is associated with restless leg syndrome, okay, which is related to iron deficiency. Number 3 is reflux, and that's very common in constipation. Number 4 is intestinal parasites, and then comes stress-related thing, but not in kids. Kids aren't that stressed. Come on, do you know what I mean? Yeah.
So in young children, like someone mentioned, like an 18-month-old bruxer, and you send them for ENT because you can see large tonsils. Most of them won't actually remove tonsils until they're a little bit older. You're talking
No, good ones will. David Lauga, he's trained in paediatrics.
Yeah. So I've
you know why? Because it's not as though they don't want to do it. They're not trained to do it.
Yeah.
Do you understand?
So I've sent to a couple like Greg and you know and Lowenja, and they're great. But then a few others that are closer to my patient.
I understand.
So
I understand.
you
know, if I had $1 for every email I get every day, Dr. Mahoney, do you know anyone in Timbuktu that does what you do? Do you understand? Yeah. So look, I have a list of very good ear, nose and throat doctors. I also have some ear, nose and throat doctors I wouldn't send my dog to if they were bruxing. You understand? You all have. Do you have good dentists and bad dentists? Of course you do. Unfortunately, you get to know. Once you find that good ear, nose and throat doctor, that good respiratory physician, treat them like gold. If you're in Sydney, Greg Lavoff, David Lauger, Professor Tom Havas, the list goes on, right? Sleep physicians, Virginia Oliveira, Jim Papadopoulos, there's good people. But there's also some ears and throats. Nothing worse when you diagnose a problem and a parent goes, oh, well, my sister, she went to Dr. Dick and, they were really happy. Dr. Dick writes back, unless there's 5 episodes of tonsillitis, I don't want to touch the kid. Are you kidding me? The kids are asphyxiating in their sleep. But I'm just a mere orthodontist with 12,000 degrees after my name. Who am I to speak to Dr. Dick? I got to convince the parent. Do you understand?
Yeah.
Good control group. Yeah. Sorry, I know. I always get that question. I was waiting for it.
It can be quite frustrating though.
I understand.
To refer off and to someone who.
But you know what? When you get a mum who gets it, oh my God, they will not stop. Women in their 40s, they hunt in packs. Who would agree? Yes or no? So you just give them the scent, right? And they'll find the right person. Seriously. Yeah. But if you're in the eastern suburbs, you're lucky. There's really good guys. I mean, this location, you've got Lavoff here and Launger and Bondi Junction, Tom Havas. Down south, I have Zoran Bekarowski. Lots of good guys who've taken the time to understand the dental side. For allergies, I just use one person, Susie Bakan. Right? Why? Because she actually does the full evaluation. She does patch testing, airborne, nasal endoscopes, and she doesn't just say, oh, well, just eliminate dust. Yeah. Stay away from dust mite. No, she actually has treatments, rhinolite, because allergic rhinitis is the hardest thing to control, and it gives you upper airway resistance syndrome. Don't think it's all surgery. Many of it's conservative treatment. And Susie will be one of the people speaking on this. So I have 6 locations, but 4 of them I own. Okay, those 4 are where I have the lectures because I own the building, and I picked different speakers in my harem. How does that sound? So if you really want to learn, I suggest this is lecture 2. We have another 10 this year, all different speakers, all linking in somewhere. Do you understand? You never learn enough. Trust me. I have a degree in dentistry, which I call my BS degree. Right? Then I have a degree in dentofacial orthopedics, in orthodontics, and in dental sleep medicine. I think I'm kind of getting the picture. But I wish I knew what I know now when I graduate, where I was... You understand? And I love spreading the word. I don't need the business. We are flat out. We're solid. You understand? But you people need to be busy. And what do you think the future of dentistry is? What do you think? Is it crown and bridge? Is it veneers? Is it implants? Anybody new grads want to learn implants when they know nothing about this? How many people do you think need this treatment versus implants? Just for instance. Do you understand what I'm trying to say? Yeah. Oh, by the way, did you get that little booklet? Yeah. That's a good summary. By the way, who's that guy? Where's Andrea? You picked that photo? Right. That's a good summary of what I'm talking about. Yeah. Really good references at the end. If you want a PDF of this, email me. I'll send it to you. Very good to send to parents. Right? So I've given you just a printout, but the PDF is better quality. Yes.
Is it the so-called head-ear effect of a CPAP in small kids?
Sorry, what effect?
Head-ear effect.
Yes, exactly.
Of the CPAP of preventing the maxilla to develop in small kids?
100%.
So for how long do you leave them on a CPAP? And when
as short as time you can. As short as time you can. So in the initial stages, while people are working out what's wrong with the kid, you put them on CPAP. Right? But the minimum time possible. Minimum time possible. Yeah. So to me, the kid has a sleep study, AHI is off the dial, bang, straight to CPAP. Then let's get an ear, nose, throat evaluation, right? Let's then look at the palate and see if they need expansion, etc., etc. Slowly, you wean them off the CPAP. And there's a good YouTube where I've had a patient on CPAP for 7 years, right? Where we've taken the kid off CPAP with this protocol And it's fantastic because the mum talks about how, you know, how grueling it was for her as a parent. The kid could never go on school camps. You know what I'm saying? Kid couldn't do a sleepover. Understand? High correlation in my study of bedwetting. Can anyone tell me the correlation between nocturnal enuresis and obstructive sort of breathing? Yes or no? That'll be $1 million question. There's a hormone released that controls the bladder in children. It's called antidiuretic hormone. Okay? It's released in good sleep. Stage 3 non-rapid eye movement. Kids who have this problem don't get to that sleep stage long enough to release the hormone, so they wet the bed. Does that make sense? Right? Adults get up and go to the toilet. Classic way of checking if a patient, an adult has OSA. How long does it take you to get to sleep? That's called sleep latency. Do you wake up unrefreshed and tired, regardless how many hours you sleep? Does your partner ever notice that you stop breathing or snore? And finally, do you have to go to the toilet once or twice every sleep cycle? Classic giveaway of obstructive sleep apnea in adults. Thank you. All right. Good luck with your IQ. You're leaving early. You're leaving early. Yeah?
I have to go back to Newcastle.
That's okay. Well, that's fine. Newcastle, don't worry. The IQ's... Don't get that on the feed, please. Good control from that city, isn't it? Yeah. Okay, so I think we'll call it a night. One last question. No? Look, please keep in touch. Do you have, Andrea, did I have my email? You have one of those grey cards? Can you give them out, the grey cards? I'll give you my personal email. It's just info@derekmahoney.com, right? Any paper you want, anything I've referenced, even if you have a kid and you're just not sure, just send me a history, send me the kid. There's vouchers in there where we're happy just to waive a consultation fees for the genuine kids. Not for every kid, but the kid who's kind of, parents are struggling and you can see a problem, and, I have what I call backdoor entries into lots of things. Do you know how long it takes for a kid to have a public sleep study in the state of New South Wales? It's ridiculous. But if you know the right people, they can, get them in a little bit sooner based on certain conditions. Did you follow? Right? So any help you need with getting your kids to the right people and the right treatment, I'm more than happy, to do. I want to teach you guys how to do the right jaw development. That's not hard, On complex cases, sure, that's specialist stuff. But just simple kids who have crossbite, mouth breathing, right, narrow palate, it's really easy for you to learn how to use an expander and broaden the palate. Really, it's not rocket science. I find if the sixes have not erupted, it's too early. That's my personal opinion based on what I've done with stability. Do you understand that? Having said that, if some kid is 5, has a functional shift, then you treat that early, because that's going to get worse. But you treat it not with plates, but with composite resin, and it has ramps and it guides the jaw. It's called planets. Yeah. So I have a dentist who comes into all my practices 1 day a week. She loves little kids. I'm not good with under 6. Does that make sense? Yeah. I had kids myself. Big mistake. Particularly when they became teenagers. Yes or no? Who realises why some animals eat their young? So I'm good with 7 to 9. Yeah, that's my forte. I'm not good with adults with my incisors, right? And the little kids. Open your mouth. My waiting room's full. I have 20 people dying in the waiting room. So this little lady comes in. Her name's Alina Blaise. You met Alina. She's lovely. She dresses up as the tooth fairy, and she does beautiful planets. So if I have the kid, yeah. Makes sense? Whereas you guys are probably straight to your paediatric dentist, yes or no? Little Johnny won't open the mouth, yes? Yeah. So yeah, I'm not good with little kids. But 7, when they can understand. And why, okay, little last quiz. 4 reasons why 7 is a good age to do this treatment. 1, cranial base is formed, so I know where things should be. I can do my Ceph analysis. 2, intermolar distance determines the thing. 3, maximum growth occurs. 4, if you look at canine eruption, it starts at that age. And you can pick an atopic canine, Erickson and Curran. So 7 to 9, magic age, magic age. 9, you may miss the boat in some girls. Boys, you're fine. Do you understand what I'm trying to say? Yeah. So 7 is a really good age for an initial orthodontic consultation, if you understand what I do. If you're only, some orthodontists don't know what to do at 7 because the premolars haven't erupted. So there's nothing to extract. Do you understand? It's quite disheartening for them. Really. All right, guys. Thanks very much. Plenty of wine. Is there food left, or if we run out of food, I'll use that time.